Hi there, I hope you're fine. In this video, I'll be talking about the Wells and modified Wells score. So before I start, this scoring needs to be done with D-dimers. And also, more importantly, the history and general physical examination as well as the systematic examination. So if you have a suspicion of deep venous thrombosis, or if there is a suspicion of pulmonary embolism in an acute setup in the emergency department, uh, this scoring system is validated for including or excluding pulmonary embolism. So the total score is 12.5. So I'll start with 3, then 3, then 1.5, then 1.5, then 1.5 again, and then 1, and then 1. So there is a 3-tier model and a 2-tier model. So for the 3-tier model, if the cumulative score is less than 2, 2 to 6, or more than 6, then it is classified as low probability, intermediate probability, and high probability. The low probability has a 1.3% risk of PE, and intermediate probability has 16% risk of pulmonary embolism. And if there is high probability, that is the Wells score, the simplified Wells score is more than 6, then the risk of pulmonary embolism is about 37%. Now, the first one, the 3, so this is essentially there is a deep venous thrombosis. If there is tenderness along the deep veins of the calf or the upper thigh, or there is shininess, or there is swelling, so this is deep venous thrombosis. Now, this 3 pertains to when the alternative diagnosis is highly unlikely. That is, you have a strong clinical suspicion of pulmonary embolism. There is an instantaneous shortness of breath. There is a loud P2, a loud delayed P2 with the splitting of the second heart sound, the P2 component of the S2. So they are split and delayed and loud. And there is, let's say, right ventricular heave, raised JVP, sacral edema, pedal edema, or peripheral cyanosis. And there is sinus tachycardia on ECG. And the overall clinical setup is in favor of PE. And the alternative diagnosis other than PE is least likely. For example, there is no suspicion of left ventricular failure, or there is no suspicion of acute respiratory distress syndrome, or there is no suspicion of some foreign body. So then the remaining are 1.5, 1.5, and 1.5. So 1.5 is when there is sinus tachycardia on ECG, 1.5, and 1.5 is when there is a past history of deep venous thrombosis or pulmonary embolism that was objectively diagnosed. And this 1.5 score is for immobility of 3 or more than 3 days, or surgery within 4 weeks, that is within 1 month. So you give the patient 1.5 score. Now we have got 1 and 1. So this one is for hemoptysis, and this one is for any malignancy on active treatment, or if there is palliative treatment, or if the patient was given anti-cancer therapy in the past 6 months. So the cumulative score is 12.5. So in 12.5, whatever the score is, you classify the probability according to that. Now there is modified Wells scoring system. Now if the score is more than 4, then the PE is likely. So I would like to talk about the simplified Wells criteria. So it essentially classifies the pulmonary embolism into low, intermediate, and high probability. Low probability is when the score is less than 2. Intermediate probability is when the score is 2 to 6. And high probability is when the score is more than 6. So that in mind, the respective risks of PE are 1.3 or 2%, you can roughly say, and then 16%, and then 37%. So now what if a patient comes to you with low probability PE, that is the Wells score is less than 2. So you immediately apply the PERC rule out criteria. That is pulmonary embolism rule out criteria. So what you do basically, you have got some parameters that even if one of them is present, then you decide further clinically. So you have got age of 50 or more than 50, heart rate of 100 or more than 100, peripheral capillary oxygen saturation on room air less than 95%, unilateral leg swelling that is more than 3 centimeter or more than 3 centimeter as compared to the control leg, and hemoptysis. If there is hemoptysis, then each of the parameter has 1 point. Recent surgery or trauma, that is 4 weeks or less than 4 weeks, or prior pulmonary embolism or DVT, or if there is a history of hormone use such as estrogen therapy. So overall, these are the elements of the PERC rule out criteria that are used for excluding pulmonary embolism. So even if one of the criteria is present, then you go for D dimer. If D dimer, then you go for D dimer. If D dimer is less than 500, then you don't need to do further workup. P is unlikely. If the D dimer is more than 500, then you go for CTPA, provided that RFTs are normal. Now, if there is intermediate probability, that is the Wells score is 2 to 6, then you go for D dimers directly. You do not do PERC rule out criteria. And same rule goes. If the D dimers are more than 500, then you go for CTPA. If less than 500, then you exclude the PE clinically. Now, as you can see, the D dimers are correlated with the Wells scoring. So this is very important. Now, if the Wells score is more than 6, that is the PE probability is high, so you directly go for CTPA. So you can pause it for a while, and then you can properly understand how you can use the Wells scoring. So that was all about pulmonary embolism, how you can diagnose it clinically. Thank you so much, and I would like to revise the PERC rule out criteria again. So it has a pretty high quality rating. So it is a validated tool, and it comes in when you have low probability of pulmonary embolism. So age equal to or more than 50, heart rate equal to or more than 100, oxygen saturation on room air less than 90%, 95%, and unilateral leg swelling, hemoptysis, recent surgery or trauma, prior PE or DVT, and hormone use. So these total 8 parameters. Out of 8, even if one is present, then in a low probability PE setup, you go for D dimers. If D dimers are less than 500, then baat khatam. And if more than 500, then you go for CTPA, RFTs allowing. So that was all about RFTs allowing. What happened to my handwriting? All right. Thank you so much for watching.